Hello, everybody. This is Dave Crawford, Director of Training Development for CASA and Trinity. This is part 2, Crisis Management and Substance Abuse Treatment. We're going to start today. We've been talking about, previously we spoke about kind of crisis management, how to respond to crisis, how to interact with clients during crisis, how to assess and prevent suicide. And we're moving on to crisis and addiction and relapse and how that relates. So first off, I'd like to say, in some ways, relapse can be the cause of an individual experiencing crisis, or in other cases, it can be a response to cope with the emotional response of a crisis. Relapse as a cause of crisis, return to substance use after a period of abstinence and stability may lead to social problems, physical and psychological problems, legal problems, relationship problems, vocational problems. They may all reemerge, increasing clients' feelings of shame, guilt, and uncertainty, helplessness, and hopelessness, which are all associated with crisis. Relapse is a response to a crisis when the individual with a substance use disorder experiences a crisis that may not directly relate to use history, but is the result of natural occurrence in life, like someone died or loss of job and eviction, something like that. Said individual may return to substance abuse as an attempt to self-medicate or escape feelings associated with that crisis. So although relapse is very common in our field and kind of what we deal with day to day, it also relates directly to crisis management. National Institute of Health says that relapse is a setback that occurs during a behavioral change process such that progress toward the initiation of maintenance of behavior change goals interrupted by a reversion to the target behavior, that being use. Current research, a dynamic, ongoing process rather than a discrete or terminal event. New model sees relapse as a complex, nonlinear, where various factors interact. Relapse prevention interventions, treatment strategies designed to limit relapse likelihood and severity, and it combines education, therapeutic exploration, and skill development. Research on relapse. At some point in the recovery process, more than 85% of individuals will relapse and return to drug use within the year following treatment. That's profound, isn't it? Researchers estimate that more than 2/3 of individuals in recovery relapse within weeks to months of beginning addiction treatment. Current treatment approaches, strength-based, what recovery capital currently exists for this person, which promote resiliency, talking about psychological resiliency there, and ability of individual to recover from relapse. It may start with a harm reduction perspective, how to reduce immediate and most severe problematic effects of behaviors while working to return clients to stability and abstinence. And I think that is a perfect definition of harm reduction, but that'll be in a future training. Again, harm reduction, how to reduce the immediate and most severe problematic effects of behavior while working to return a client to stability and abstinence. Motivational enhancement, that's another very common approach with relapse prevention. What stages of change was person in before relapse and what might help them return to, based in De Clemente's and Pacheco's trans-theoretical model stage of change, and then include pre-contemplative stage, contemplative, preparation, action, and maintenance. And if you worked in most treatment agencies, that's pretty much what the foundation is, or the core of the way the system is designed based on the stages of change, the early recovery to advanced recovery groups, kind of determining what interventions are appropriate for what stage of change a person in. That's kind of like the whole core of what we do. The trans-theoretical stages of change further explained. Pre-contemplation, this is the stage people do not intend to take any action in the foreseeable future. People are often unaware that their behavior is problematic or produces negative consequences. The contemplative stage is the stage where people are intending to start a healthy behavior in the foreseeable future, and they recognize that the behavior may be problematic, and more thoughtful and practical consideration of pros and cons change before the behavior takes place, with equal emphasis placed on both. So the pre-contemplative is we're not even thinking about making any changes. We don't even see a problem exist. Contemplative stage is kind of like we're starting to see some problem areas and maybe looking at things that it's time to change some things. Preparation stage. In this stage, people are ready to take action towards a plan for recovery. People may even start to take small steps towards the behavior change, and they believe change in their behavior can lead to a healthier life. In the action stage, it is the stage people have recently changed their behavior and intend to keep moving forward with the behavior change. People may examine this by modifying their problem behavior or acquiring new healthy behaviors. That's active recovery. Maintenance stage. In this stage, people have sustained their behavior change for a while, defined as more than 6 months, and is intended to maintain the behavior change going forward. People in this stage work to prevent relapse to earlier stages. The trans-theoretical stages of change, with relapse as part of that model. The relapse stage is sometimes included in the stages of change model in recognition that a person might have some or many small lapses or even relapses. Periods when the addictive behavior is taken up again before maintenance is achieved. So I know that when I'm teaching groups or talking to clients, like relapse is definitely part of the stages of change, but it's not like a requirement. You don't have to say, well, I haven't done a relapse yet, so let me check that off my list. But it's just recognizing that it is part of that process. And I like what it said here, that it can involve small lapses or a relapse. There is a difference there. Lapse is kind of like a slip, short-term, quick return to use, and then, hey, I messed up, let me get back on track. Where relapse would be like a return to a full relapse is like a return to behavior and substance use, like before you even got engaged in treatment. The outcome of the process of change is highly about the individual. Some people are able to adjust quickly, return to the stage of change they were in before relapse. For others, they may return to active use and return to a lower stage of change. So that what I'm saying in there is that, like I just previously mentioned, relapse, and many times it can be very therapeutic and provide an opportunity for growth for a client. Say, if he's working on people, places, and things type thing, and he or she returns to go hang out with some friends that they used to use with and cause relapse, they might be like, well, I'm not going to do that again. So it's the opportunity to learn from that lesson. Other times, I think what happens is a person goes back to use and kind of can go back to the pre-contemplative, contemplative stage where they're not really even trying to think about or really work a program of recovery. Sometimes only after relapse that a person discovers what recovery from an addiction means to them. How I think about this, I kind of just went over this. How I think about relapse is part of the stage of change. If a person has a relapse and stays active in treatment, well, what might help them return to one of the recovery stages that before relapse occurred, such as preparation, action, or maintenance stage. So that's what I was talking about, where an individual might just kind of say, oops, I messed up, let me get back on track. If relapse is not identified through self-report or client or through clinical observation and intervention is not provided, as client may no longer engage in treatment. So client relapse, stops coming to groups, stops coming to appointments. That is much more probable that individual will return to early stage, such as pre-contemplative, contemplative stage. And while the trans-theoreticals aren't necessarily part of the crisis management, I do think it's important to define them and how they relate to relapse. Internal factors, and individual susceptibility, changeable for transient factors. Susceptibility to relapse is individual set point or initial threshold for relapse. Personality, genetic, or familiar risk factors during sensitivity. So if you're in a vulnerable situation or recovery and you're kind of like being faced with some emotions we ain't felt in a while, or being around external stimulus that might trigger or cause a person to lead back to use. That's what they're talking about here. Cognitive faculties, such self-efficacy, personal beliefs about abstinence or relapse. Current or changeable factors that prevent use, strategies and plans to deal with urges and craving, development of coping strategies to combat impulsive and maladaptive coping responses, development of coping strategies for emotional regulation, development of self-efficacy skills, and identification of individual motivation for change and outcome expectancies. So these are the things that we should be working on when we're doing relapse prevention planning. It is important to note why relapse, when identified and responded to quickly, can offer an opportunity for learning and growth in a person's recovery. Use itself may change motivation and create impaired judgment and return client to pre-contemplative or contemplative stage. Common causes for relapse: negative emotional states, interpersonal conflict. So if they're fighting with family, fighting with spouse, social pressure as a response to crisis, which is pretty much this why we're talking about relapse today, and co-occurring mental health diagnoses are all like highly correlated with relapse rates. Relapse and dual diagnosis, the co-occurring diagnosis. When working with dual diagnosis clients, relapse is highly likely. Change can be very hard to maintain due to complexity of problems, and we need to remain positive when relapse occur when working with the client. Keep that non-judgmental, just work to get the client back on track, work to re-engage, and do the best we can. Addressing relapse: step one, assess intensity, frequency, and duration of return use. Then you want to work to stabilize the client through re-engagement if the client dropped out, or through changes in amount of support level of care. So if client's outpatient, had a period of abstinence, return to using 2 grams of cocaine a day or couple bundles of heroin, then we might want to consider sending the person inpatient detox. That's the higher level of care. Relapse education, topics such as benefit of relapse prevention planning and how relapse can offer opportunity to learn from mistakes to both educate and minimize any feelings of guilty or shame. So that's where you really want to tie that in, that relapse can be part of recovery. So a client just isn't beating themselves up and recognizing addiction as the disease that we all know it is. Recovery planning, warning signs identification, warning sign management, and coping strategies. Step 5 would be inventory training, identify strengths, would promote resilience to return to abstinence. That's when working with the client. Step 6 would be family involvement, assess quality and quantity of family involvement, as research demonstrates a 50% reduction of relapse occurrence when supported family involved with treatment. Again, that means supportive. The families, part of them, people that need to be changed, because families, the ones that the client might be using it, that might not be the family you want to involve as part of relapse planning. Or on the flip side of that, when you have family members that care and support the client and are committed to recovery, you definitely want to bring them in. Step 7 would be follow up, monitor progress, and evaluate for client outcomes. Counseling techniques that to be used during relapse, urge surfing. So focusing on areas where the urge is being felt and noticing what is occurring. So that kind of involves, like, it's a cognitive behavioral intervention, and it's kind of like learning to identify those cravings and triggers so that we can start like redirecting self, teach the client to redirect self. And that's where the urge surfing comes in. Mindfulness-based relapse prevention applies the concept of mindfulness to the management of urges that can derail sobriety. So noticing what we're feeling in the moment, what's going on, where our thoughts are leading us, being mindful of the moment and kind of unpacking that with a relapse prevention perspective. Experiential activities, guided imagery, playing the tape forward. I think we've all heard this, like learning as a coping strategy. If you're feeling urges, working with the clients, is like follow that drink through and see where that decision's going to lead somebody. So playing the tape forward. Decision matrix for both immediate consequences and delayed consequences of use, identify positives and negatives. That's what decision matrix is. Mapping is a visual representation counseling strategy that's geared towards improved decision-making that can enhance any therapeutic or psychoeducational relapse prevention exercise, either in group or in individual settings. And then also just doing some work again, the 10 most common dangers associated with relapse: people, places, and things, negative emotions, positive emotions, which I think that gets underlooked a lot. I mean, person's in a big mood to celebrate, they could also trigger some feelings around use. Boredom, use of any drug, because all roads eventually lead. Physical plane or emotional plane, glorification of past history and behaviors associated with use and lifestyle. A lot of money, if someone comes in a lot of money, that can be a trigger. Prescription drugs prescribed, so someone's working a program and some doctor just happens to give them oxys and they didn't identify there in recovery, then that could lead them right back out complacently in one's recovery. So just saying that person's starting saying they've got a lick and they don't need to be in any self-help or treatment anymore. And then the last one, halt, hungry, angry, lonely, or tired. And any of those can be things we need to work on relapse prevention planning. Outcome results, relapse prevention. 9,504 participants from 26 different residential program treatment outcomes were studied. Relapse prevention planning generally showed some success rates. It reduces substance use, improved psychosocial functioning, and it was used in both individual and group counseling, useful across drug classes, no matter what the drug of choice is, and 50% more effective in supportive family involved, and more effective combined with pharmacotherapy. I hate that word. Pharmacotherapy, you know what I'm trying to say, sorry. Emergent response for opiate overdose. And we're going to talk about Narcan now, and naloxone is the official name. It reverses overdose due to opiates, heroin, Oxycontin, Percocet, Vicodins, methadone. It wakes a person up who has had an opiate-related overdose within minutes. It blocks opiates for 30 to 90 minutes. It may cause, and that's important because people wake up and they're automatically withdrawal, want to use it. It's not going to do nothing when they still have Narcan in the system for that amount of time. It may cause withdrawal if the person who overdoses built up a tolerance to opiates. It will, like I just mentioned, it will not cause harm if it is not an opiate overdose. So do not hesitate because you're not sure if the overdose was caused by an opiate. So we're going to talk about benzo overdose for their own. So basically, if you suspect someone's an overdose and it's heroin related, give them Narcan, even if it's benzos or just something else, it's not going to hurt them. How to recognize an overdose. Major signs is a person is unresponsive. Something's wrong with breathing, shallow or no breathing at all. Breathing is noisy, snoring, or gurgling. Other signs might be blue around the lips, nail beds, loose pink color, eyes with pinpoint pupils, and your intuition just says this is an overdose. What to do in case of an overdose, steps to take during overdose. First, try and wake the person up. And that means shake them, shout, hey, don't slap them or anything like you see in the movies, but you can take your knuckles and kind of grind it into the chest. It's called a sternal rub or sternal grind. Call 911 and administer naloxone, Narcan. Both are essential, and do whichever is quickest and easiest. So maybe you can say, hey, call 911 to someone while you start working on administering the Narcan, or you call 911 and do, but you got to call 911 as well. It's pretty important. If the person hasn't started breathing normally after 3 minutes, you can give them another dose. If the person begins to breathe but cannot get up, place the person in the recovery position. I have some pictures and videos further down that's going to go into this a little bit further. If the person has not begun to breathe, do rescue breathing or chest compression if you know how. So here we go. First, try and wake the person up, shake them, shout them. If no response, grind your knuckles into their breastbone for 5 to 10 seconds. And then there's a little image there kind of showing how to do that. Emergency response for opioid overdose, call 911 or have someone call 911. Administer the Narcan. Hold the sprayer between thumbs and 2 fingers. So kind of like that. Do not test spray. Spray entire dose in the nostril. Repeat after 2 to 3 minutes if the person is still unconscious. Check for breathing. Give CPR if you have been trained to, or do rescue breathing. Tilt the head back, open the mouth, and pinch the nose. Start with 2 breaths in the mouth, then a breath every 5 seconds. Continue until help arrives. I have a video that shows it, and then further down, I have another video that kind of shows how to administer Narcan, and it also does chest compressions and rescue breathing. And I do want to be clear, in no way is this intended to replace the certification from CPR training or anything like that, but I do feel like earlier on in one of the slides, it said that if you know how, I know if you're like me, if someone's dying, I think we want to try everything we can. And even if we aren't CPR trained, I think we're going to at least try to give it a shot. So trying to prepare you the best you can. But again, this is not official CPR training, just kind of a video shows you how to.
How to provide rescue breathing and chest compressions in an overdose situation. Helping a person breathe by doing rescue breaths and chest compressions is important to keep the brain alive during an overdose. These steps may also be taken if you have given naloxone to a person who is overdosed and are waiting for the medication to take effect. These are the signs you should look for before beginning rescue breathing and chest compressions. The person is unconscious and not waking up. They don't respond to shouting or rubbing knuckles on the breastbone or between their upper lip and nose. They are not breathing normally. To begin rescue breathing, if the person is not breathing, follow these instructions. Open the person's airway by placing one hand on the forehead and the other hand on the bony part of their chin. Gently tilt the head backward, slightly lift the chin. Make sure their airway is clear. Pinch the person's nose shut and cover their mouth with yours. Take a regular, not a deep breath. Give one rescue breath for 1 second. Give a second rescue breath for 1 second. You will know you have given enough air when you see the person's chest begin to rise with the breath you give. As soon as you see chest movement, stop that breath. Be careful not to give too much air. If the person's chest doesn't rise on the first breath, try repositioning the head or the airway and trying another breath. To give chest compressions, follow these instructions. Once you have given 2 rescue breaths, do 30 chest compressions. Here's how. Place the heel of one hand on the center of the person's chest. This is the lower half of the sternum. Place the heel of the other hand on top of the first hand so that the hands are overlapped and parallel. Push hard and fast, 2 inches deep for anyone over the age of 1. Allow the chest to fully return to normal position after each compression. For every 2 rescue breaths, give 30 chest compressions. Within the space of a minute, you should give between 100 and 120 compressions. For guidance, try to imagine giving compressions to a normal beat of row, row, row your boat. Keep doing rescue breathing and chest compressions. Stop if the person begins to breathe normally on their own, they regain consciousness or wake up, you are exhausted and can't continue. EMS, police, or other trained first responders arrive and take over care. Although the risk is low, mouth-to-mouth rescue can transmit infectious diseases. Consider your own safety before providing assistance. Devices such as a pocket mask or face shield are designed to protect you while you deliver rescue breathing and should be used according to the manufacturer's recommendations. The Good Samaritan Law provides some legal protections to anyone who gives naloxone and calls 911 in an overdose situation. For more information or to obtain CPR training, visit the American Heart Association's website at heart.org.
All right, that was it. How to give chest compressions and rescue breaths. And again, not to replace any CPR training, but just kind of give you a how-to. I mean, again, if someone's overdosed and the ambulance on their way and we have an opportunity to save a life, I think that most of us in that situation would want to. So that gives you some basic knowledge how to. All right, so after you get the Narcan, stay with the person. It can wear out, remind them when they wake up that it can, it wears off 39 minutes. So even if they wake up in withdrawal, then use isn't going to automatically fix that. It's just going to block all the receptors associated with that. Stay with the person till help arrives. And when the person wakes up, explain what happened. What to say when a person overdosed when he wakes up, explain what happened, gave you Narcan, naloxone, advise against using more drugs. Narcan will prevent the drugs from working, and building up more drugs in your system may cause you to overdose again. When the Narcan wears off, if feeling withdrawal, it should wear off in 39 minutes and go to see your medical provider. So again, I got one more video here and that kind of shows how to administer. And after that, we're getting pretty close to the end and we'll wrap this up.
Saving a life in an overdose situation. This short video will show you how to give naloxone and provide rescue breathing and chest compressions in an overdose situation. Take these steps if a person has any signs of an overdose. Call 911. Give naloxone. Start rescue breathing and chest compressions. To give naloxone, follow these instructions. Remove naloxone from its packaging. Insert the applicator tip into the person's nostril. Spray the entire container up one side of the person's nose. If the person is not breathing normally, begin rescue breathing and chest compressions. To give rescue breathing and chest compressions, follow these instructions. Tilt the person's head back and slightly lift their chin. Make sure their airway is clear. Give 2 rescue breaths, watching to see their chest rise. Then give 30 chest compressions. Here's how. Place the heel of one hand on the center of the person's chest. This is the lower half of the sternum. Place the heel of the other hand on top of the first hand so that the hands are overlapped and parallel. Push hard and fast, 2 inches deep for anyone over the age of 1. Allow the chest to fully return to normal position after each compression. For every 2 rescue breaths, give 30 chest compressions. Within the space of a minute, you should give between 100 and 120 compressions. For guidance, try to imagine giving compressions to a normal beat of row, row, row your boat. If the person is not moving after 2 to 5 minutes, repeat all the steps, alternating between rescue breaths and chest compressions until the person moves or first responders arrive. Call 911 if you haven't. Take these steps after giving naloxone. If the person moves and is breathing on their own, place them in the recovery position on their side. Call 911 if you haven't. Stay with the person until they go to the hospital. Someone who was given naloxone is at risk of overdosing again after the naloxone wears off. How naloxone works. Naloxone, also known by brand names such as Narcan and Evzio, is a medication used to block the effects of opioids in an overdose situation. When sprayed into the nose of a person who is overdosed, naloxone works quickly and can save their life. Here's how it works. When the entire container of naloxone is sprayed up one side of the person's nose, the contents are absorbed by the tissue in the nasal cavity. The person does not need to be breathing for the nasal spray to work. Depending on individual circumstances, it can take about 10 minutes for naloxone to fully work. Calling 911 and starting rescue breathing and chest compressions can keep an overdosing person alive while naloxone takes effect. Be sure to wait 2 to 5 minutes between each dose to allow the medication to work. The effects of naloxone are temporary and last only about 30 minutes. This is why there is still a danger of overdosing once naloxone wears off, and why it's important to stay with the person until they go to the hospital. If you or someone you know is struggling with an opioid use disorder or is in treatment, you can get naloxone to carry or keep in your first aid kit. Naloxone is available at select pharmacies or can be obtained free at distribution sites throughout Vermont. Your provider may also prescribe naloxone if you're being prescribed a high amount of opioids or take other medications that increase the risk of overdosing. The Good Samaritan Law provides some legal protections to anyone who gives naloxone and calls 911 in an overdose situation.
All right, that kind of just goes over everything we discussed, and that definitely was intentional. I do want to note that we frequently will send staff to different programs to provide Narcan training, but this, as you are getting started, kind of gives, if you are not familiar with Narcan, how to administer Narcan, I wanted to give you at least a core working knowledge of what that is in case you encounter overdose before we provide the training. Emergency response for drugs or alcohol overdose. So this is anything besides opiate. Before I get into this, I do want to be clear. Opiates is the most prevalent and the most highest risk for fatality with all the substance use, but it can happen with other drugs. Benzos would be another one that might cause, it can lead to fatality. The prevalence is low, but it can happen. Benzos, if you're not familiar, are medications used to treat severe anxiety or panic attacks. Commonly used benzos include Xanax, Valium, Klonopin, and Xanax. The brand name for, I can't even say that. Alprazolam is a prescription drug that is prescribed to treat anxiety and panic disorders. Valium, the primary brand name for diazepam, treats anxiety, alcohol withdrawal symptoms, and seizures. Klonopin, the main prescription name for clonazepam, is primarily prescribed to control seizures due to epilepsy, but also used to treat serious panic attacks. All three of these medications are benzodiazepines and have the potential to become addictive or to be abused to achieve a high. Fatal benzo overdose are rare when the substance is being used on its own. However, certain factors can put a user at risk of serious consequence during overdose. If you come in contact with someone who may be experiencing overdose for benzos, please call 911 immediately. Flubenazole may be used to help reserve benzodiazepine overdose in emergency room settings. So that's not something we carry on us. Like, again, if back to the Narcan, if you come across someone and they seem like they're having an overdose and you suspect it's opiate, give them Narcan, call 911. It might be a benzo use. For some reason, the two are commonly used together, so it could be one or the other. And we do not carry that one, but we have to get someone somewhere where they can get help. If you suspect that you or someone nearby is suffering from a drug or alcohol overdose, call 911 immediately. Do not leave the person alone. Stay with them until medical professionals arrive. If you witness an overdose and the person has passed out, they should be placed on their side in case they vomit. So again, that's just in any situation where you might encounter something, regardless of what the substance you use or if you do not know. All right, so that is it in a nutshell, and that wraps up our crisis management trainings. We will be tested on the modules, and after that, we'll be counted as completed. Have a nice day.